Policymakers continue to debate reform of the U.S. immigration system, but these political debates overlook an emerging healthcare crisis, the growing population of older, undocumented adults, many of whom have lived and worked in the United States for decades, and their need for medical care. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with David Velasquez, an internal medicine resident physician at Brigham and Women's Hospital. Dr. Velasquez has co-authored a perspective article about access to health care among older undocumented immigrants. Dr. Velasquez, under federal law, what types of health insurance and health care do undocumented immigrants have access to?
Under federal law, undocumented immigrants are really limited in what they can access. Currently, they are eligible for really only emergency treatment under EMTALA. And so if an undocumented immigrant shows up to the emergency department and has an urgent or emergent issue, they can receive treatment there. Beyond that, undocumented immigrants can access some level of healthcare through community health centers, many of which do receive federal funding. But at many of these centers, access can be limited, especially when it comes to specialty care access. And oftentimes, the centers might be under-resourced and might actually have closed in recent times because of financial pressures. And so access to healthcare services when it comes to federal services provided to people in the United States are really limited for undocumented immigrants.
And then beyond community health centers, what about the state and community level? Are there steps being taken there to increase access?
There definitely are steps being taken there. I'll start with state level. So we're seeing a number of states across the country that are trying to advance healthcare access for this population. The perhaps most notable example is California, in which starting this year, they essentially now cover all undocumented immigrants regardless of age. And they do that by allowing them to essentially be eligible for the Medi-Cal program, which is their state's Medicaid program. There are other states across the country that are taking similar approaches where they allow immigrants, sometimes a specific type of immigrant, that is, immigrant children or immigrants who are pregnant, to access healthcare services through other programs, such as opening up the exchange. In Colorado, I believe, they have opened up their exchange and allowed some immigrants to apply for health insurance that way. And Washington itself is also utilizing a Section 1332 waiver to essentially do the same thing. And so we are seeing states across the country utilizing different levers to allow undocumented immigrants greater access to healthcare. When it comes to the local level, what I'm seeing, and this is more anecdotal than anything, with some research behind it, is immigrant groups, a lot of community organizations, CBOs, community-based organizations, that is, and community health centers trying to expand their outreach to these groups who are very vulnerable during this time. And so that's what we're seeing on the ground here.
What's known about the healthcare needs of this undocumented population?
I'll preface this by saying that it is difficult to ascertain all the needs for this population, given their tenuous legal status. There isn't the same amount of data available for, let's say, a particular racial or ethnic group as there is for the undocumented population, because oftentimes we don't know when someone is undocumented. And so the data is limited. But what we do know in general is that they tend to have a high level of both social needs when it comes to food insecurity, housing instability, and so forth, in addition to medical needs. They do tend to suffer from higher rates of high blood pressure, hypertension, of course, in addition to certain cancers. And this is compounded by the fact that healthcare access is limited for them. So even though we know that they have higher or a disproportionate level of healthcare needs and social care needs, they unfortunately aren't getting that care that they need in order to fulfill and meet those needs.
In your perspective article, you focus on older, low-income undocumented adults, including those you call dual non-eligible people. Could you explain that term and explain why you think this population deserves particular attention?
So our perspective is focused on this population we term dual non-eligibles. The dual non-eligible population we define as undocumented immigrants who are equal to or over the age of 65, who, excluding their immigration status, would be eligible for Medicare and Medicaid. We know that if you are a US citizen in the United States, you do qualify for both Medicare and Medicaid if you meet certain income and other eligibility criteria. And so we looked at the population that, if they were to be US citizens, would qualify for these programs. So that's the population we're talking about here. This population we were particularly interested in looking at, we being me and my co-authors, because this is a population that is increasingly becoming a dominant segment of the undocumented community. They are aging. If you look at the number of individuals, undocumented individuals in the age 50 to 64 range, many of them are going to age into the over 65 range, and they tend to have a high level of healthcare and social care needs, as mentioned earlier. And so it is important for this population to receive healthcare services. And this is something that I see in practice. I work at a community health center, and I see people who are in this age group and also of this immigration status, and they have a high level of healthcare needs. And one can only imagine the thousands and tens and hundreds of thousands of others who require similar healthcare. And so we wanted to focus on them because of their healthcare needs, and also because I think there is an argument to be made for this population where this is a group who has lived in the United States for a very long time. Many of them have lived and worked here for decades. And during that time, they have paid into Medicare, they have paid into Social Security, they have paid taxes. But as we know, they have not qualified for those benefits at the end of the day. And so we thought that this was a population with not just the need, but also that the argument needed to be made for them receiving healthcare.
So what are some of the policy solutions that you think could help improve access for this group of people?
So we discussed three policy solutions in our perspective. The first policy solution goes back to the idea of community health centers providing care for this group. As mentioned earlier, the community health centers are vital. They have for decades treated anyone that requires some level of healthcare. And so we, in our perspective, recommend essentially funding these community health centers through a couple of different mechanisms. The first is by looking at migrant health centers. So these are health centers that essentially cater to a population that tends to be predominantly migrant-based. Farm workers, for example, is the prime example. And states can provide more funding to these kinds of health centers. They do receive most of their funding federally, but states can, we believe, step up and provide them with more funding, given that we do see that undocumented immigrants, especially those who are elderly, tend to continue to work into old age because they don't have a safety net to rely on. On top of that, there is an argument to be made for community health centers to just more generally receive funding and support by other institutions. There are examples across the country, but we highlight a few here in the state of Massachusetts where the Blue Cross Blue Shield of Massachusetts Foundation has provided grants to a number of organizations that serve this community, the undocumented community, the dual non-eligible community. Similarly, there are other programs that we've seen, not even in just the healthcare space, but in the legal space, where states here in Massachusetts, for example, are providing grants to these organizations that are focused on not just newly arrived immigrants, but immigrants in general. And so I think that's one way to do this. The second big way that we talk about is by reforming the financial assistance policies that we have. As the NEJM readers are very much aware, financial assistance is a program that allows income eligible people to receive free or discounted care through nonprofit hospitals when they meet certain income eligibility criteria. And unfortunately, we've seen that many immigrants are being excluded from accessing these services, even though it is these immigrants who are providing some level of funding to hospitals through the taxes that they pay. Nonprofit hospitals are tax exempt, and they receive a lot of benefit from tax-paying individuals. And so we think that broadening the criteria to include them rather than exclude them is one way to improve care for these folks by ensuring that they do not lead a life into medical bankruptcy. And then the final way that we discuss in the paper has to do with Medicaid and Medicaid lookalike programs. I alluded to this earlier in this conversation, but there are a number of states that are taking different approaches to ensuring this population, and doing that by adopting programs that are essentially like Medicaid, but primarily use state funding is one way to expand coverage to this population.
Finally, in a related perspective article, Santos and colleagues describe state policies that require information on citizenship status to be collected in healthcare settings. How would you expect such policies to affect the health of this population?
I think that such policies are most likely to discourage and disincentivize individuals from the dual non-eligible population to seek access to care. And there is data to support this kind of thinking. We saw that with the introduction of the public charge rule, even before it was implemented, but simply with the idea that public charge was going to be into place, public charge being the rule that essentially would make it harder for any individual applying for permanent residency or other legal status to achieve that status because they are deemed a burden on the government by using public services. We saw that when that rule took place in, I believe it was 2019, the enrollment in programs like Medicaid and SNAP decreased for mixed status families, that is, families who have people that are US citizens, in addition to undocumented individuals. So we saw enrollment drop. And so we really saw the effect that rules or policies like public charge, like the one being put into place in Texas and Florida, are likely to do. And so I think overall, likely to discourage folks from this group. And I don't think this is good policy. I think that we need to create policies, especially in our healthcare system, that are welcoming and that are inclusive and that focus on the health of people rather than focusing on identifying who should or should not receive care at the end of the day.
Thank you, Dr. Velasquez.